Today, we have with us our beloved director of ultrasound. Well, he was the director of ultrasound and now he's semi-retired. Let's welcome Dr. Mostafa Atri.
The reality is ultrasound is better than definitely CT for some indication, and even better than MR. And when you do them all, you know the advantage of one over the other one.
Why do you think that there is this over-reliance on CT and MR in most of the centers? And why do you think that that does not exist in Toronto?
And we teach astronauts to do ultrasound.
Absolutely.
Because just think about it. You go all the way up there.
In the space
you
station.
have to abort. All of that for a right lower quadrant thing.
Mostafa, it's such a pleasure chatting with you always. I've enjoyed discussions with you. But let's start at the beginning. So you've been a radiologist, semi-retired. So you've seen the entire evolution of radiology from when it began to now. How did you get interested in ultrasound? How was ultrasound at the beginning? And what was your role in that in Canada?
So I did my medical school in Iran. I graduated from Tehran University. And then I came out to do my residency in Canada. And the plan was to go back, like the majority of the graduates did that. And my idea of doing residency was doing medicine, and I loved cardiology. That's what I wanted to do. But I could not find a medicine residency, so I found radiology. So I started radiology, started getting interested in radiology, and that was the beginning of cross-sectional imaging. So that made it more interesting. And it was actually the very beginning of real-time ultrasound.
Okay.
Ultrasound used to be contact scanning. It wasn't real-time.
Contact scanning as in?
You use equipment that you just scanned like this.
Oh.
There was no real-time scanning. So real-time was the second generation of ultrasound.
Okay.
And in fact, the origin of real-time ultrasound was at McGill. And it was at Montreal General Hospital, which is the place I ended up going.
Oh, that's where you train, okay.
And the people who started real-time ultrasound, I was probably kind of second generation.
Perfect.
But like I said, this was the place that real-time ultrasound started.
Okay.
So we were at the beginning, we kind of taught ourselves. But I really love doing it because I like using my hands, and that's why I did some intervention.
Over your time, how do you think ultrasound has evolved, especially like in an academic center like ours?
So if you look at ultrasound around the world, there are three models of ultrasound.
Okay.
One is the ultrasound that is done entirely by physician.
Okay.
And I would say that is the majority of the world. The majority are probably Europe, and the rest of the world outside
India,
Europe,
Brazil,
including where you come from, it's done by physicians. The second approach is technologists doing all the ultrasound. And that's what happens for the most part in the US. The third model, which is the model that we have at UMIC, and this is the model that I started when I was at McGill at Montreal General. So it was a team of radiologists and technologists. Then when I went to Sunnybrook, I started the same thing there. And then at UMIC, that's the way we do ultrasound. So the value of that is big. So we go in, like you said, just to do focused in one area. So we have more time to improve our technique.
So when you mean focused, you're like the technologist scans it, and then in some specific areas where you have a concern, either clinically or you think that there's something wrong, then you go in and just scan that particular area.
Yeah, there's a mass in the liver. They don't know what the mass is.
Okay.
So you would go in, but you also have the medical knowledge.
Yes.
That helps in terms of what to look for.
And also what to ask the patients if they have any other
ask the
history.
patient.
Yes.
Plus, you have looked at CT and MR potentially. So that helps you to look for what you're looking for.
Absolutely.
And so what this results in that you become better technically for focused ultrasound because you don't spend a lot of time. You also bring the knowledge from CT and MR and see how you can reproduce it. So some of the things that we did at UMIC with ultrasound, the origin is in CT or MR. But because we learned from CT and MR, we try to reproduce that by ultrasound. So that's how we made ultrasound like more advanced. So a couple of things that we did, we started bowel ultrasound as a routine examination, and we placed it in the hospital that saw all inflammatory bowel disease. So that now is an integral part of doing or taking care of inflammatory bowel disease.
Absolutely.
The other thing we started was endometriosis mapping.
Yes.
Endometriosis mapping, again, when I started that, I had some knowledge from MR. So we transferred MR knowledge to ultrasound. And the reality is ultrasound is better than definitely CT for some indication, and even better than MR. And when you do them all, you know the advantage of one over the other one.
Yeah, absolutely. Yeah.
So what happens, I always believe that, yes, the literature helps to say that this technique is accurate, but it's when you sell it to the clinicians.
Yes.
When the clinician trusts that now, even though I have had a CT of the bowel or even MR, I think ultrasound can give me more information. They do ultrasound after that, and they use ultrasound as a triage because they trust in it.
Yeah.
The endometriosis mapping that we started, now we see patients to come for ultrasound mapping after MR because there are things that ultrasound is better than MR.
better at that.
So there are areas that, and this is what the clinicians have told me because they trust in it. So I know we are doing a good job.
Absolutely.
Otherwise, they would not refer patients to us.
Yeah.
So that's how you advance ultrasound, you bring new techniques when you combine, like you bring the clinicians, physicians into the
picture.
Practice of
That's
ultrasound.
amazing. So essentially the three models is just radiologists doing by themselves or a technologist doing by themselves. And then finally, you have techs doing the general scan, radiologists going in for focused. And that's the perfect blend because it allows time, it allows for innovation, it allows for doing new things. But then also you need a champion as a radiologist there pushing it to the boundaries of what is possible, then publishing on it, and then taking it to the clinicians, pointing out how useful it is and kind of bringing it all together.
Yeah.
But if you look at the current day, in most other centers in Canada and probably even in the US, you find that the default for most indications is CT or MRI. Now, CT and MRI are not saying no, but for some, ultrasound is equally as good or better in some areas over the other. But why do you think that there is this over-reliance on CT and MR in most of the centers? And why do you think that that does not exist in Toronto? Because here I found that this is one of the places where clinicians trust ultrasound a lot compared to any other place.
Okay. So I think that starts with the philosophy. You have to have a team of sonologists who actually believe ultrasound is, in some areas, better than CT and MR. And as a result of that, they push for that indication. If you look at, for example, acute lower quadrant pain or acute pain with a place of painful, like tender area that patient has, at Sunnybrook, places that I have at least worked, it always starts with ultrasound.
Okay.
So as a result of that, lower quadrant pain territory is ultrasound territory. And in some cases, we even bring patients from CT to ultrasound because we know that ultrasound can provide some information that CT cannot provide. As a result, in these places, ultrasound becomes the starting examination. I have had fellows from Europe who actually came on the staff that they say, why are you doing so many ultrasound for appendicitis? Why don't you just do CT?
The CT, yeah, exactly.
By the end of their fellowship,
Yeah.
they accepted that ultrasound is a better way of doing it. So it's basically, you have to have a team of ultrasound believers so that you can promote ultrasound. And then, like I said, there are areas that ultrasound can add to CT or MR. So you can bring the patient from CT and MR to provide more information using ultrasound.
Yeah.
Like if you look at US, that a lot of information comes, it is all tech.
Yeah.
So as a result, they don't rely on ultrasound the way the places that radiologists are involved would rely. So they become complacent on CT and MR, and they just bypass ultrasound. The other advantage of actually, from our point of view, I mean from Canadian or even European approach to imaging, is you can take care of a lot of things with ultrasound. That if you don't have good ultrasound, they would end up going to CT or MR. And if you look at the limited access to CT and especially MR,
yeah, with CT you have radiation issues, especially in young patients when we talk about like all this inflammatory bowel disease, young patients, repeated scanning. And MR, the issue is also that there is a limitations in number of scanners available.
Number of scanners.
And the time taken to do per MR is longer, so you cannot kind of fit in a lot of patients.
Yeah, and that problem exists in Europe too. It's only in US and some even developing world that you have a lot of private. But there's no access to everybody. So in European system and Canadian system, that we want to have access to imaging by every member of the community, there's not enough MRs. There's not even enough CT. So you have to promote ultrasound. And if you do good ultrasound, a lot of these patients don't need CT.
Absolutely. So your solution to a lot of, we talk about imaging backlog. There's backlog for CTs and MRIs in which patients, there are huge wait times. And what you're saying is that for a lot of these indications, ultrasound may be as good or probably even better than these in specific indications. So the solution is to have more ultrasound kind of everywhere and then kind of do it for more patients.
And better ultrasound.
And but
more expertise.
The expertise is kind of what's important. So in your opinion, do you think that ultrasound has to become ubiquitous and everybody is kind of doing it at the bedside? Like the traditional thought when you talk about a doctor or a physician is that they're wearing a stethoscope, right? Do you think that, I don't think anybody uses a stethoscope these days.
Yeah.
Or it's very rare used. Do you think that it has to be replaced by an ultrasound?
Well, it would definitely be replaced by ultrasound, but that requires time. So the time is, you need to train every graduate in medical school to do basic ultrasound. And we have to accept that you can do only basic ultrasound. And I have the same opinion about POCUS ultrasound. Point of care ultrasound. I totally agree with point of care ultrasound, as long as the ER physician knows the limitation that they have. So I actually was involved in initial POCUS ultrasound at UHN. We sat down with the ER physician, and they had very stringent criteria, which they are not likely to miss important pathology. So they were not looking for appendicitis. So if you do that,
appendicitis
then
is technically very
that's
demanding.
technically difficult to get. As long as they stick to that, I have no problem with even definitely replacing the stethoscope. There's no reason to do a clinical exam to see if his spleen is big. You can easily do that, and you don't have to have a lot of knowledge to do that. So these are basic things that medical students should be taught. And if they know that, then they can do basic things. They can do bedside ultrasound. As long as they don't, it's the same as like a stethoscope. A stethoscope, once you are, at the time that we use a stethoscope a lot, once you had a complicated case, you get a cardiologist. So that is important teaching that you have to learn when you graduate from medical school, that you have to know your limitation.
So I was, a couple of years ago, I was looking at these thingies in which now we have these wireless ultrasound probes. And it's even more beautiful and elegant these days because one side it is curvilinear, the other side it's linear. Just completely wirelessly you can charge it. You can connect it to your iPhone or iPad. Which means that it is completely portable these days. You don't need to push around the whole machine. You just kind of have it in your pocket and take it and go. It's just so compact. Hopefully that kind of
so we can talk about actually the value of having that kind of access to ultrasound, which would be one of the main advantages of ultrasound when we talk lack of radiation is portability, right?
Absolutely,
As a result, especially with that kind of ultrasound, you can have ultrasound everywhere. And if you look at long term, you can probably remotely, real time, monitor ultrasound. That should
okay.
be feasible. This is
absolutely.
actually something that we wanted to do. So one of the advantages is, I always thought, like, if when you have in war zone, you want to know if somebody is injured,
Yeah,
what's the degree of injury? Like,
wow, okay.
do they need to be flown by like in plane to somewhere to get access to medical care, or it's not that bad? Or when you have disaster area, you have earthquake, you have something, you can quickly triage individuals.
Yes.
Which one needs immediate assessment? But in fact, when I was in Montreal, Montreal is very advanced in simulation for flight simulation. It's actually well known. Like even
wow.
American come there.
Okay.
So they approached us to get involved in ultrasound scanning of astronauts.
Oh, wow, okay.
So the idea was, can we teach astronauts to do ultrasound?
Absolutely.
Because just think about it. You go all the way up there.
In the space
you
station.
have to abort all of that for a right lower quadrant pain.
Absolutely.
So
yeah.
I think
What do you
now
do?
actually that is implemented.
Okay.
So that's
wow.
implemented. Again, you have to do basic ultrasound. They're not going to be trained for doing more advanced ultrasound.
And even then, like, as you point out, they don't really even need to know how to interpret these images. All they need to know is how to kind of scan. And then somebody here can be live streaming that, telling them, hey, actually, you know what, go lower, press harder, move this way.
Yeah.
So they can be directed that way and be able to do it. That's amazing.
So actually, there's a very good indication to do that in Canada, considering in the north, the access to imaging is limited.
Yes, and Nunavut and all these.
Yeah, and most people don't know that. In the north, there's always a nurse on site, but they have rotating physician.
Okay.
So we actually, and Heidi was involved, through the practice in Thunder Bay, we wanted to train nurses in these remote areas to do basic ultrasound.
Oh, that's nice.
And we were prepared to monitor it like live.
Okay.
So if you can do it through an astronaut, you can definitely do it through a node.
Absolutely, yeah.
Something that most people don't know, a lot of these remote areas, there's not even a road to these areas. They are all have to be flown in by flying. So a indigenous person has a right lower quadrant pain. It costs $10,000 to fly just to get an ultrasound in the closest place. So I think by now we should have trained enough nurses there to do basic ultrasound, and you can remotely monitor these ultrasound. I think that would be really the future of ultrasound, the portability of ultrasound.
It's amazing.
It is amazing things you can do because it is portable. You can't do any of these with a CT, MR. Like this is, and like you mentioned, because the minimization of all the equipment that we have, you can have it everywhere.
Yeah, the only downside I can think of is that because as the costs come down, people are going to be able to buy their own. Then they're going to scan it, and then they're going to be worried, oh my God, what am I seeing? Because they don't understand what it is.
Yeah,
they're going to send images to you asking, hey, what is this? Oh, that's just your stomach. Don't worry about it.
So that's the part that you have to know your limitations.
Absolutely. Yeah. Because I think one of the first things which I realized about ultrasound is that as opposed to CT and MR, a lot of times it is not very intuitive what you're seeing. Like CT and MR, okay, this is liver, this is spleen, this is where it is. But because an ultrasound is scanning in all angles and planes, and everything looks kind of very grayish, there's quite a steep learning initial curve, which really means that while it is applicable in certain scenarios like nurses, astronauts, and stuff like that, it's really not ready for the common public to all have a probe and then scan themselves, because it's going to cause more problems than it kind of solves. Right?
Just think about it. When I think about that, we are doing remote surgery now.
Yeah.
Right? Robotic remote surgery. Why can't we do remote ultrasound? That's exactly the same thing.
That's one of the easiest ways to start.
And it's easier to do that.
So in future, what do you think are some of the, like, not even in the future, currently, what do you think are some of the more emerging indications, use cases, or applications of ultrasound?
Yeah. So there are areas of ultrasound that's already established, but it is not uniformly distributed. One example is elastography.
Okay.
Elastography, we know MR is better than ultrasound. We
Okay.
have enough data that MR elastography is better than ultrasound.
So elastography, you're measuring the firmness of the tissue.
The stiffness of the
Stiffness
tissue.
of the tissue.
And you can grade.
Yeah, so especially
the
in like
amount
liver
of
disease and cirrhosis.
Yeah. So that, again, when I mentioned I believe in clinician, if clinician thinks something works, you know that it is working. You don't even need a lot of data to know it is working. You may have noticed that when I was way back at General, when we did biopsy for liver parenchymal disease, we used to do a lot of random biopsy of the liver.
Yes.
Recently,
Just
we
to
don't
assess
do
for
a lot.
fibros.
Why? Because hepatologists believe in elastography. They have their own elastography machine. It's not very, you don't need to know a lot to do elastography. Also, if you look at the number of patients that need elastography, it's not practical to use MR to do population elastography. So that's something that's already there. It just has to be pushed and distributed. The other example is our contrast ultrasound.
Oh,
that
yeah, okay.
is well developed at TGH and at UMIC. It's not distributed. We know how you're involved yourself. You know how much contrast ultrasound can do, but there was billing problem. So we have not been able to convince the system to pay better for this. And as a result, you take advantage of something that is amazing, really. You know, if you don't see flow with contrast ultrasound, it has a negative predictive value of 100%.
Yeah, I want
is
to
there
talk about-
anything else in medicine that has a negative predictive value? So, and why are we not using this routinely? So these are things that are already there that we just have to promote it and
Yeah.
distribute it.
So for people who have not heard about this, I want to talk about contrast ultrasound a little bit because we're one of the few centers who are doing it. Not a lot of places have it, so not a lot of places see it or even understand what it is. So for those who are listening, contrast ultrasound is when we administer contrast similar to CT or MRI, but the contrast is tiny, tiny microbubbles, which means that it has zero negative effect on the kidney at all. It's completely kidney safe. And the beauty of this is that the microbubbles are just exhaled through the lung, and the visualization of contrast is better than CT and MR. And generally when you, like I spoke about this to a lot of radiologists who primarily do MR work in the US, generally when people have just done ultrasound, the grayscale, they're like, how is contrast going to add? But once you see it, they become believers because it's a night and day difference between grayscale ultrasound as to how steep a learning curve is versus contrast ultrasound as to how clearly things are seen right there. And for some of these indications, it is amazing. And it is such a pity that we're not doing more of it in many more indications. CT has radiation risk, and a lot of times we don't know if things are enhancing or not, for example, in renal masses. MRI, motion artifacts all over the place. But you have a renal mass, administer contrast, you clearly know if it's enhancing or not. And that's absolutely amazing.
Because the bubble, as you know, is micron size.
Yes.
And they can enter capillaries.
Yeah.
So as a result, there's nothing else
Yeah.
that can enter like MR,
capillaries,
CT
yes.
at that level. That's why it has a negative predictive value of 100%. One bubble, you can see it with ultrasound. So if there's no bubble in that area, there's no blood vessel in that area.
That is amazing. So one of the main areas where contrast ultrasound has been used, at least in abdomen, has been in identification of HCCs, right? So I find that it is better than CT or MR sometimes in characterization and identification of washout because it is like a continuous. So it was kind of very interesting for me when I moved here because initially I kind of relied on CT and MR, and then I came here and I'm like, hey, how is it's going to be useful? And it's really, really useful. And then we now have elastography, which can identify parenchymal disease before it becomes HCC itself. So it's identifying fibrosis. But now we also, I understand we have fat quantification, which can identify fat even before it becomes fibrosis. So I think that we are pushing the boundaries of ultrasound, identifying diseases earlier and earlier with kind of these newer techniques coming up and stuff. So do you think that there's going to be like a population level screening for fatty liver and all of that in future, or?
So again, definitely MR is going to be better than ultrasound, but you don't have access to MR to do MR at the level of general population.
Mm-hmm.
So once the fat quantification is better developed by ultrasound, that would be fat quantification, elastography would be routine part of evaluating the liver. Another thing that is new is like actually with respect to contrast ultrasound, there are other things that are potentially useful with contrast ultrasound. One is that they are not putting chemo agent within the bubble of contrast ultrasound.
Oh, wow.
You know, some of the chemo agents are very toxic.
Yes.
So you can give the patient high dose because it damages other parts of the body. So they would put them in the bubbles and then they break the bubble in the area of interest.
Wow. So
the agent would come out and it's not could be toxic. The other thing contrast actually does is a lot of chemo agents cannot cross blood-brain barrier. With contrast ultrasound, if you break it, you open blood-brain barrier. So you can do that and then use chemo agents that now can cross the blood-brain barrier to get to the tumor.
To where it is.
So these are extension. The other thing is actually, apparently, if you break bubble in an area that you want to radiate, it increases sensitivity to radiation.
So there are like by chemotherapeutic agents, or
no, just the radiation itself.
Oh,
if you break the bubble, that tissue becomes more sensitive to the radiation.
Wow.
So these are other things that we are at the start of evaluating them.
That's amazing. So you're moving from diagnostic to the
therapeutic and management. The other thing is HIFU. HIFU,
high intensity focused
ultrasound, that we are using it for fibroid.
To ablate the fibroids.
To ablate instead of embolization. Yeah. But now we have started using it in thyroid cancer. Like, so for superficial things, they are using it for prostate cancer. So HIFU can be used again for management. That would be very useful.
Oh, that's amazing. So many things have come up and so many things have changed. And where do you think AI fits in all of this? Are we using AI in ultrasound?
Well, AI is already used in technology of ultrasound. Like when you play with the machine, some of the things that you have noticed that some machines you can just press a button and it improves
the image quality.
So this is all AI. So with more advanced AI, this is going to be much better. It gets to a point, because that is one of the areas that expertise helps. That the tech, sometimes even techs who have been doing ultrasound, they don't notice some of these changes they have to do to get better images. With AI automatically is going to improve. And as a result, people who are very beginner in ultrasound, like that clinician or a focus ultrasound, they don't need to have a lot of ultrasound physics. So AI is going, or even for biopsy, AI probably makes it much easier to biopsy a focus because it can just tell you where to go. And in terms of interpretation, I think soon AI would do fetal measurement, would do cardiac chamber measurement. Like these are things that is already there. In terms of tissue characterization, it's more tricky because, as you know, acquisition of CT and MR is very standard. Ultrasound acquisition is not very standard. And as a result, two ultrasound images could be very different. But with more standardization of the ultrasound with the AI, that would be improved as well. I think even right now for places like, say, prostate cancer, thyroid, breast, that ultrasound technically is not difficult to find the lesion. AI may be easier to be used for interpretation.
For interpretation of it. Yeah, so that's bang on. Like, but you did speak about that in CT and MR, image acquisition is standardized. That it's always axial, coronal, sagittal, whereas in ultrasound, we're kind of going at all different angles and the images are not standardized. Is this one of the limitations of ultrasound, and what are the other reasons ultrasound, like what are the overall limitations to widespread use of ultrasound?
Well, it is definitely one of the limitations, but I tell trainees this limitation is actually makes ultrasound better because it's probably one of the last techniques that will be taken over by AI. If you look at CT and MR, it's easier to
Absolutely,
take.
yeah.
Ultrasound is going to be a long time. So I tell like ultrasound technologies, your job is actually secure
Fair
much
enough.
longer than other technologies.
True.
But with AI, when it becomes more standardized, then yeah, it would be easier to use that. You add that, for example, to robotic ultrasound. Robotic ultrasound is going to come. Again, right now, robotic ultrasound has the same limitation that because ultrasound acquisition is so versatile and complicated, it may be difficult for robot to reproduce it. But long term, with AI and all of that, robotic performance of ultrasound would improve.
Wow, okay. Before all these robots come in, I still think that one of the primary limiting steps of ultrasound is the expertise of the person doing it. It's very operator dependent as opposed to anything else. So I understand training has to be one of the crucial parts of it. So where do you see training on ultrasound, and are there any issues with that? Can it be improved?
Yeah. So in my short experience with the clinic, I haven't noticed the issues with training because you definitely need more physicians to be interested to do ultrasound. As we discussed, to have a more optimal ultrasound, you want to have a combination of physician and tech. But no matter how good the clinician is or radiologist is, you need to have excellent technologists because that they are the ones who do the general scanning.
So Mustafa, with even all the current existing limitations, ultrasound has still shown that it's as good, if not better, than a lot of other modalities. And the solution to a lot of these problems seems to be to have more widespread ultrasound, as well as to push the boundaries to be able to do better.
Yeah.
So do you have any kind of last words for trainees or anybody who's interested, not just trainees, but also the technology, younger technologists, or people who want to get into ultrasound technology as not just physicians, but sonographers, as well as in biomedical technology who wants to improve that? Do you have any word of advice for all of them?
I think it has to start from radiology level. It should be radiologists who push for better quality technology teaching and emphasize that we need to have better technologists. Because even if you are there in a clinic, the vast majority of the cases are done by ultrasound techs. So they are the ones that have to be improved. So, and that has to come, it's not going to come from technologists themselves. It has to come from the radiologists who are the last person who put his or her signature on the report.
Absolutely. So Mustafa, so your summary is that radiologists should be excellent and also demand excellence from the technologists, and then things will flow through. When the radiologist is excellent, he'll find more indications, and then the technology will improve and the technologists will also improve. And that close connection is ultimately our responsibility.
Exactly.
Thank you very much, Mr.
You're welcome.
Thank you very much, Mustafa. You have always been a source of great inspiration to all of us. And we hope that you have fun during your retirement.
Thanks
Thank
for
you.
having me, Satish.
It's always a pleasure. Thank you.